All right, there we go. Okay, so I thought I would start with a fasting study that was just published. Now, granted, this was in mice, but I always feel like mice are a reasonable starting point. It's definitely not a human trial, but in this trial, they took 4 groups of mice and they fed them 4 different ways. So they gave one group an ad libitum all day diet, meaning that they could just eat as much as they want all day long. There was just food out all day. The second group had food out all day, although they had 30% calorie restriction, so less calories available all day. And then the third group, you could eat as much as you want, but only within a 3-hour window. So kind of an intermittent fasting or time restricted eating. And then the fourth group, they had the same 3-hour window with calorie restriction. And what they noticed was that in 3 of the groups, all except for the ad libitum all day, so if you had any kind of calorie restriction or window restriction, there were improvements in glucose and insulin. And interesting, they were really doing this to look at longevity. And they found that there was an increase in longevity in both of the time restricted feeding window groups, but not just in a 30% calorie reduction group. So even though the 30% calorie restriction helped a little bit in the glucose and insulin, it did not actually increase longevity. So interesting. And I wanted to share a few salient points from the fasting group challenge. So some of you were in that group, but we took 10 people. They were not necessarily obese. We had BMIs ranging from 25 to 38. So an average BMI of 29, which is considered in the overweight group. Weights ranged from 168 to 231. Glucoses, fasting glucoses ranged from 85 to 122. And insulin ranged from 3.3, which I would consider already an A+, to 17.8. HOMA-IR, which is an insulin resistance score that uses glucose and insulin in their calculation, showed in HOMA-IR 0.7 to 5.4. I would consider pretty good less than 1.2 and good less than 1. So we already had a couple people that had good insulin sensitivity. And then I gave you an average before, a range after, an average after, and the difference. So we noticed some weight loss anywhere between 5 and 12 pounds, or an average of 9 pounds of weight loss over the 6 weeks. So just to refresh what we did, over the 6 weeks, participants chose 2 days, non-consecutive days, in which they would do some time-restricted feeding. Our goal was to actually get to 2 days where you weren't actually eating. You could drink water or coffee or tea. And some participants actually did that early on. Some did that after a few weeks. But most people significantly improved their fasting times. So even people who were not familiar with fasting at all and started with maybe a 16 or an 18-hour window, ultimately got to 24 hours and then to 30 and 36 hours. So it was, I think people surprised themselves at how they could incorporate that. And again, we saw some weight loss. We saw a decrease in BMIs. Fasting glucose remained on average about the same, but you could see that our highest glucose at 122 actually came down to 111, so moving in the right direction. Same with insulin, moved in the right direction with a lot lowering of 0.7 on average. And the insulin sensitivity improved as well. So you can see the highest insulin sensitivity of 5.4 came down to 4.2. So I thought it was a success. I think we all learned something about ourselves. We learned something about how labs move. So everybody had slightly different drops, and some had raises. We had some that had a little struggle during the course, but overall I thought it went very well. And then, because I always like to talk a little bit about cholesterol, because I think there's so much misinformation about cholesterol and LDL being a bad cholesterol, which I don't agree with. This was a study from the NHANES database from 1999 to 2014, where they looked at 19,000 people. They looked at their total LDL levels, so the LDL cholesterol level, and all-cause mortality. So not just looking at heart disease or, you know, if somebody had an MI, but did they die of other causes? So total deaths in comparison to LDL level. And then they adjusted it for age, sex, race, marital status, education level, smoking status, BMI, hypertension, diabetes, cardiovascular disease, and cancer, because those things might have actually impacted results, right? So they balanced for all those things and then looked, could cholesterol by itself predict for anything? And what we see is that, so I don't know if you can see my cursor here, but the LDL of less than 70 actually had a hazards ratio of an average of 1.3, which means that there was 30% more likely to die of any cause with a low LDL. And I've seen that multiple times in different data sets where if we get LDL too low, we actually start causing more problems. LDL is actually a part of our immune system. LDLs of 70 to 99 had a slight decrease, the hazard, or a slight increase in all-cause mortality with a hazards ratio of 1.1. If you were between 100 and 129, you were kind of smack dab in the middle, so no risk. So those actually, so back when I was in medical school, those would be considered normal. Now they put the upper limit of LDL at 100. And then for 130 to 159, there's no statistically significant difference because that error bar crosses the 1, but it is slightly lower. And if you're even over 160, again, you're kind of still on that 1 line. So those aren't considered different. But they put this graph together, and I thought it was really a nice line graph, looking at all-cause mortality on our y-axis and the x-axis being LDL cholesterol. So even up to 300 LDL, some patients actually have reduced all-cause mortality. So you can't just look at LDL and say high LDL is bad. There are some patients who have higher all-cause mortality with a higher LDL, but if you get into the very low numbers, you see that all patients do worse. So again, lowering LDL too far is a problem, and the sweet spot might be right around 120 to 130, which would be considered high on our standard lab panel. So just food for thought. This is a study that was done on saturated fat. So dietary saturated fat, looking at the risk of ischemic and hemorrhagic strokes in Japanese and in non-Japanese, and I'll explain the data. So there were 5 studies that looked at the intracerebral or brain hemorrhage, so that would be a bleeding stroke, versus 11 studies that looked at ischemic strokes or loss of blood flow, like a clot or something. There was a meta-analysis done that it excluded subarachnoid hemorrhage, so that would be like maybe trauma or something, so not an actual intracerebral bleed. And what they found was that there was a very strong inverse association, meaning less likely to have a stroke if you ate higher saturated fat, if you were Japanese, but not in non-Japanese. It didn't mean that you were higher if you were non-Japanese. It means that there was no difference. So there was no positive or negative association if you were non-Japanese, but if you were Japanese, there was actually a significant inverse association with the amount of saturated fat in the diet. So they do better if they eat more saturated fat. A meta-analysis looking at ischemic stroke, or again, clot or loss of blood flow, showed a mild inverse association. So again, still better, just not as strongly better as the hemorrhagic stroke in Japanese, but again, not in non-Japanese. But again, there was, if you look, a hazards ratio of 0.93 actually means there was a lower risk. It's just that the confidence interval included the number 1. And when it includes the number 1, it means it crosses that middle point line saying that some people did better and some people did worse, and it wasn't statistically significant. So saturated fat, from a stroke perspective, is better or not worse than having a low saturated fat diet. And I came across this one. This is a new one out. It was just published only as an abstract at the Rheumatology National Conference. And this was a study. It was called VITAL, and somehow it stands for vitamin D and fish oil supplements and autoimmune disease. But they took 26,000 patients, and so adults that were randomized, and it was double blind. So patients didn't know and doctors didn't know what they were getting. And it was placebo controlled. So that means half of the patients got placebo. And they actually did a 2x2 design, which means that a quarter of the patients got vitamin D and placebo, a quarter got omega-3 and a placebo. One group got placebo, and the other group got vitamin D and omega-3. And interestingly, they followed these patients out for quite a while, and the difference started to show up after a few years. So after 6 months, where maybe some trials look at 6 months and say, oh, there's no difference, this actually got better and better the longer patients were on this. And I'll show you a graph. But 5 years of just 1 gram of EPA, that's one of the omega-3. Normally, when I recommend a patient to take vitamin or omega-3s, I might recommend EPA and DHA. But this one was just EPA, 1 gram, and or the vitamin D supplements for 2,000 IUs daily. And it was associated either or both with about a 30% reduction in autoimmune disease. So if we look at this graph, I think you can see how all those curves separate. So the black line was placebo, and then the other 3 lines had one, the other, or both of those supplements. And you can see they all pretty much do equally well, although the active omega-3 that was just omega-3 alone is the green line, and they actually look to do the best at kind of the 1 to 3 years, but then the lines all cross. So I don't know if we can really say anything about that. But that's it. Important. I mean, I think vitamin D is one of the best supplements, and I think omega-3s are probably the next best supplement, because even if we're eating a lot of fish, our fish don't tend to carry as much omega-3s as they used to. And I've shown this slide before, but to go back to kind of the COVID thing in vitamin D. So this is looking at vitamin D levels. So the red would be severely vitamin D deficient, or a level of 10 here in the US. Mild vitamin D deficiency is in the orange group, that's 10 to 20. Insufficient D, 20 to 30, and then sufficient D over 30 is the green. And you can see that if we look at moderate COVID-19 disease, there are more of the orange, blue, and green in it, whereas if we go up to severe, we see more of the red and orange. And when we go up to death, we are very much in the orange and red groups. There's a little bit in the green. So it doesn't mean if you're sufficient, you can't have those things, but it is far, far less likely. And, you know, there's not very many greens in those. And to be honest, most people are probably vitamin D deficient in our world today, because we don't go outside very much. When we do, we cover up or put on sunscreen. Our fish, although fatty fish can carry some vitamin D, it's not a lot. And this is another one where I think that it points to, not only do you want to be over 30, but you probably want to be up toward 40. And to be honest, there's some breast cancer literature that says you should be over 60 to decrease risk of recurrence. So I do try to push patients up to the high end of the normal range as opposed to the low end of the normal range. But in this table, there is the red line, which is the rate of death. And it's compared to the vitamin D concentration. So if you are in vitamin D levels of 17, 18, that death rate was 100%. And as you slowly tick up in vitamin D concentration, you start coming down. And as you approach 30, it certainly is coming way down, but past 34, we don't really see anything. So if we can get up into the 30s, 40s, again, most people recommend higher than just 30. So this was a study that just came out this month, and I thought it was quite interesting. So this took a military population. So you'd anticipate that they're pretty healthy for the most part and pretty active. But what they did was a survey looking at health-related behaviors, and then what were the odds of getting a COVID-19 hospitalization. So they had 93 cases that got hospitalized compared to 372 non-hospitalized controls. And then they looked at this self-reported health-related behaviors. They matched them for things that might make a difference, like BMI, activity level, disease history, psychological distress. And what they found is that you were more likely to be hospitalized by 84% more likely if you were sleep deprived. So if you got less than 7 hours of sleep compared to 7 to 9 hours, you were more likely to be hospitalized. And when we look at sugar sweetened beverages, if they drank more than or equal to 3 sugar sweetened beverages per week, not per day, per week, they were 75 or 74% more likely to be hospitalized compared to the group that had less than 3 sugar sweetened beverages per week. And interestingly enough, there was no difference based on fruit or vegetable intake. And this was a great YouTube video that I saw, and there was the clip, if you Google or go on YouTube and search by Death by Sugar by Jorge Cruz, there's about a 5 to 8 minute video and shows a gentleman who's eaten low carb, lost a lot of weight, and they pricked his finger, put the blood on a slide and looked at it under the microscope. And he had these beautiful round red blood cells. His blood looked picture perfect. You could put that in a textbook. And then he went into their kitchen and ate a bunch of carbs, drank a glass of orange juice, had some Pop-Tarts, had a Coca-Cola. I can't remember what else he had, but he had a significant amount of sugar, and then immediately went back into the room, pricked his finger, and you see the second slide. Look at how clumped those red blood cells are. And there's a lot more in the cytoplasm or in the serum space. You can see these lines and probably some fibrin or some kind of sticking material. And so what I truly believe and what has been shown in the literature is that if you are eating sugar, especially on a regular basis, you are clotting up your blood so that if you do, heaven forbid, get a COVID infection, a SARS-CoV-2 infection, that you are far more likely to have problems because your blood is not operating the same way. You get the clots, you can get bleeding. I think we've seen quite a few of these weird blood disorders. And this is a very telling slide just by changing what you're eating. So the more you can eat low carb, the more beautiful your blood looks and the more healthy you will be. So to get on to why we talk about low carb, well, this is blood sugar on an individual who's a little bit of a pre-diabetic, eating a higher carbohydrate meal and seeing a big swing in blood sugar, way up to 180, but then starting to crash at about 3 to 4 hours. And that comes from insulin, and we'll go over that in a minute. But if we eat a very low carbohydrate meal, so maybe some beef and fat and greens, we get a very stable blood sugar over many hours. And insulin is really what we're looking at. Insulin is a growth factor for cancers. It's also an inflammatory, so it does create joint inflammation. It can create a lot of inflammation throughout your system. It's associated with many of our chronic diseases. And when we have even a smaller carbohydrate load, we can watch how the insulin responds. So we know that sugar is going to go up, glucose is going to go up with a carb load. And what we want to know really is, what is the insulin doing? How much insulin is our pancreas putting out? And only the group in the green Number one category is having a normal insulin response. So it jumps up, but it comes right back down. And by about 2 to 3 hours, it's back down to baseline. If you're in groups 2, 3, or 4, you're having a hyperinsulinemic response. And you can see 4 actually started quite high and remains high for many hours. And if you're not eating again, that continues to push your glucose down. And so often people in that group 4 will feel what we call hangry. They start to get panicky because they aren't eating, because really their blood sugar continues to get pushed down, 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 and they need to kind of refill that blood sugar because insulin is not operating properly. So 2 studies I'm going to show on breast cancer. So this is about insulin resistance and looking to see if patients who are getting chemotherapy for breast cancer have a complete response versus not complete response. And a complete response, if you might guess, would be they get chemotherapy and then they go and get their lumpectomy or mastectomy. And is there cancer left in their breast or not? And so they took non-diabetic women, because we know that diabetics already are insulin resistant, but they took non-diabetic women with locally advanced breast cancer who were going to get neoadjuvant chemotherapy. And of those, 25 patients did not have insulin resistance based on what they used as a cutoff, and 30 patients did have insulin resistance. Now, they used the same HOMA-IR that I just showed you in our fasting patients, but they used a cutoff of 2.5 as insulin resistance. And I would fight that a little bit. I would say a minimum of, I would put 2, but I would even consider putting it lower, like 1.9 or 1.5. But anyway, they used 2.5 in this study. And what they found was that the probability of having a pathologic complete response was over 4.5 times lower if your HOMA-IR was high. So it was 44% chance of having a pathologic CR if you were insulin sensitive, and 16% if you were insulin resistant. So insulin resistance matters about how we respond to treatment. This is a poster presentation that was done looking at Oncotype scores. So these are women, the average age of them were 62. They all had lymph node negative breast cancers. They all had an Oncotype score done, and then they looked at whether or not they had metabolic syndrome and categorized the groups, whether they were low risk Oncotype, intermediate risk Oncotype, or high risk Oncotype, and how they did. And so I'll blow up this one section here. And what they found is that if you had a low risk Oncotype score, but you had metabolic syndrome, so metabolic syndrome, let me go back and define that. Metabolic syndrome is usually if you have 3 of 5 features. Those 5 features would be central obesity, high glucose, high triglycerides, low HDL, and hypertension. And you have to have 3 of those 5 things. And if you did, you get classified as metabolic syndrome. I'm assuming that's how they defined it as well. And what they found is that if you had metabolic syndrome with a low risk Oncotype score, you were 23 times more likely to have a recurrence compared to somebody who in that same low risk group that did not have metabolic syndrome. In the intermediate score group, although the odds ratio was 3.9, it crossed that 1. So it wasn't considered statistically significant, but if you look at those limits, it's 0.9 up to 15. And so there's probably some impact in that group as well. But in the high score group, there was less, there was more below and more above. And so there was less of an impact. It was 0.8. So we would say that didn't mean anything. So in a high risk or in a high score, all of those people were getting chemotherapy. So maybe chemotherapy offsets some of that metabolic syndrome phenotype. We don't know that, but that would be an assumption. And in the intermediate score, some of those patients certainly did get chemotherapy. It's possible that that is what changed that. So my bias is even if you have a low score and you're not going to get chemotherapy, we certainly can fix metabolic syndrome and put us in a lower risk group. So how do we do that? Well, we want to follow a well-formulated ketogenic diet, or a very low carb, quality protein and fat type diet. So the first step is always to remove the sugars, the grains, the vegetable oils. Vegetable oils are key because they can, in theory, be included in a ketogenic diet because they are zero carb, but they impact negatively cancers, cells, joints. They are inflammatory to your body. So vegetable oils, so those are the soybean oil, corn oil, canola oil, vegetable oils. So any nut, seed, or vegetable oil, as opposed to a fruit oil like coconut or avocado, or animal fats like butter, ghee, lard, etc. The next step is to remove processed and packaged foods. So we really want to read labels. We don't want to fall for any keto products. So many keto products are really not great. They have ingredients that you would never eat as whole foods, meaning the first thing in keto bread is wheat flour, but we just said we want to get rid of grains. So why are we eating wheat flour? That is processed grains, which makes it even worse. So anyway, removing processed and packaged foods, and then eating below your personal carbohydrate tolerance. So even if you're eating a real whole foods diet with meat and fish and eggs and vegetables, there are some vegetables that are higher in carbohydrate, typically the root vegetables, the starchy vegetables, or the sweeter tasting vegetables are going to be higher in carbohydrate than the leafy greens and the cruciferous vegetables. Above ground vegetables tend to be the better choices. Same goes with fruit. Sugary fruits are a problem. Nuts and seeds can be a problem if we overeat them. I usually stick with macadamia nuts in a small quantity, which tend to have the lowest in omega-6 fats, highest in monounsaturated fat. Satiating because they're very rich. Make sure that we're getting adequate protein. We want to fuel our protein matrix, right? We want to give enough protein to build muscle and to build bone. So we don't want to be losing muscle, or at least to maintain. As we get older, we need a little bit more protein. We don't digest it as well. We don't absorb it as much. So our protein requirements actually tend to go up as we get older. And one of the things I find that most people struggle with if they've been following a low-fat diet is that they end up eating low-fat and low-carb, which is very painful because you need fuel, and you're going to get fuel in the shape of carbs or in fat. So we're going to replace our carbohydrates with fat. So fatty cuts of meat, eggs, avocado, again, avoid the omega-6 fats. But I usually say the ideal fat is the fat that comes along with your food. So don't be afraid of choosing fattier foods. And then step 6, based on the original slide with fasting, I think time-restricted feeding or intermittent fasting is great. Exercise, we know that HIIT exercises and resistance training are actually better at improving insulin resistance. Doesn't mean you can't do cardio, but you got to include the other stuff. We want to get quality sleep. We saw how that changed COVID outcomes. So that is affecting our underlying immunity. So getting quality sleep and getting good sunlight, get vitamin D if you can get outside. And if you can't, I would strongly suggest you supplement with vitamin D. So the main thing is that we're going to eat real whole foods. We are going to eat animal proteins like eggs, fish, beef, pork, poultry, lamb, organ meats if you can tolerate them. I think liver is a superfood. It's like, multivitamin on steroids. Natural fats, again, the fats that we find in proteins, the fats we find in plant foods. If you want to use some olive, avocado, coconut oil, great. Butter and dairy fats if you tolerate them, although I would say don't overdo them, especially if you're trying trying to lose weight, because that's one that you can overeat pretty easily. Aim for the leafy greens and non-starchy vegetables. Those, again, tend to be the above ground vegetables. You can include nuts, seeds, and berries, but I would strongly encourage you to limit them. So these are just from Diet Doctor, some pictures of carbohydrate content, and you can see the above ground vegetables tend to be very low in carbohydrate, as are the animal proteins and fats. Their Diet Doctor, for whoever hasn't been on their website, they have a lot of great information. And then I always want everybody to read labels. So most people would pick up this mayonnaise that says olive oil mayonnaise dressing and look at the carbs, and it's less than 1 gram, so that's good to go. But it's, even though it says with olive oil is the third ingredient. Soybean oil beats it out. In addition, it's got sugar added and it's got potato starch in it. So making your own or getting other brands that are cleaner is more optimal, or replace it with something else. So depending on what you're using it for, could you replace it, with some sour cream or some Greek yogurt? Could we add some butter instead? Can we do something different? So I thought this was a great post by somebody saying academics classify this as red meat. And what is it? Pepperoni pizza. They would also classify that as processed red meat. But meat is like one small portion of that, right? It's mostly carbohydrate. And then we have some fats from cheese. So the actual meat on this pizza is a very small percentage. These are other pictures of things that would be classified in a classic. Anytime you see meat causes something, these are what they include as meats. Any meat-based meal. So a meatball and spaghetti counts as meat, and hot dogs in buns count as meat. And they don't usually control for other foods that they're eating. And these are all things that they will count as eggs. So when we see that eggs are bad, this is why eggs are bad. I think we would all agree that a bunch of desserts and pasta are bad, but they're all made with eggs, and therefore they get counted as eggs in many trials. So just remember that pizza and fast food and sedentary behavior and smoking and drinking and being overweight, those are the things that are always associated with eating red meat. And so when red meat gets demonized, it is not the people on the right who are exercising and they are eating, meats with veggies and eggs and not eating the carbohydrates, the processed foods, the fast foods. And just so you know that restaurants almost always cook in those soybean oils. So even if you're going and trying to pick something good, I'll tell you, they're almost always fried or grilled in that fat. So just be aware. So I will open it up to questions.